Okay, so this is my approach to an ECG. This is not the most correct way as per your OSCE settings, for example. There are a number of videos on YouTube which will talk you through the actual method of going through an ECG for an OSCE setting. However, I should like to think this video will prove very useful. I use this method particularly in the A&E setting when I'm looking for something more acute, and it gives you an insight into the considerations I take when interpreting an ECG. So once again, just a polite reminder that the ECG essentially is a reflection of the electrical activity of the heart. It is a 360-degree representation of the heart itself. And although it's primarily used to understand the electrical conductance and the activities related to that, this can give us information about the structure of the heart also. And I'll hopefully use some examples as I go along. Okay, so first and foremost, what we're going to look at is the actual details of the patient, and you need to understand that we need at least 2 patient identifiers. And the 2 identifiers I'm going to use here are the name, and I might use the date of birth, which I've not put on here. You could use the NHS number, or you could use the hospital number as well. So these are 2 typical identifiers. Now, next thing we want to look at is the date of the ECG and the time. Usually that will be written somewhere next to it or nearby. The last thing I typically then will look at is the speed at which the ECG was conducted, as well as the voltage at which it is conducted. Speed is really important. Why? Because we will understand and appreciate that this strip that we've got before us here is it's actually 10 seconds in duration, given that this was conducted at a speed of 25 millimeters per second. And that becomes really important when we are calculating the rate of the rhythm, of the strip rather, so the heart rate. The next thing we remind ourselves is that each large square is worth or equal to 0.2 seconds, and each large square is made up of 5 smaller squares, and each of those small squares is equal to 0.04 seconds. So the 5 small squares will give me 1 large square, which is worth 0.02 seconds, and if I have 5 large squares, then that's equal to 1 second. As such, I will have 50 squares here to give me my 10-second strip. Okay. The next thing to look at, and the first thing to look at really for me, is this lead over here, lead number 2. And lead number 2 essentially is used. Why? Because it's going to help us to understand and calculate the heart rate. Now, there are a number of ways in which we can calculate heart rate. I will, if I haven't already done so, a separate video on that. But just before going back to lead 2, the other thing I was going to mention, is that I can confirm this is a 12-lead ECG. Okay, that's the other thing we want to appreciate. Then lead 2, I'm going to look at these R waves. So these are our R waves, you'll see from our previous video. And you're going to look at the regularity to see that these R waves occur at regular intervals. One of the best ways to kind of then calculate the heart rate essentially is you can calculate the number of large squares between 2 consecutive R waves, or between the R waves, and then you can do 300 divided by those large squares. So here, for example, we'll do 1, 2, 3, and it's just short of 4. If that was 4, then we'd say, well, 300 divided by 4 gives us a heart rate of 74 beats per minute. Now this is a little under 4, and so therefore this is going to be a heart rate that's slightly over 75 beats per minute. That's one of the ways. Now, this way we can do, this method we can use only if these R waves are regular. So the R to R intervals have to be regular in order for me to use this method. If, say for example, the R to R waves, the R to R intervals are irregular, and they are irregularly irregular, then that method falls by the wayside. And in that situation, what I would recommend doing is count all the R waves that are in this 10-second strip, and say for example, well, whatever it comes to, you then times that by 6, because don't forget we said this strip is 10 seconds long and we've got 60 seconds in a minute, so therefore times it by 6. So the number of R waves in an irregular pattern, then we can use that the second method. Okay, so that's that. We then we use this method to calculate the heart rate. So we've done heart rate. Okay. Next thing we want to understand is the rhythm sinus. So is this sinus rhythm? Now, what do we mean by sinus rhythm? Sinus rhythm essentially is such that you have a P wave followed by a QRS complex followed by a T wave. So every single QRS complex is predisposed by a P wave and followed by a T wave, and we've got PQRST. We've got PQRST, PQRST, and this goes on. And because we have got PQRST, we've got sinus rhythm. Now, the next thing is, well, the R waves, as we've already identified, are regular. The R to R intervals are regular, so therefore this is deemed as being normal sinus rhythm, NSR. If, however, these R waves were not regular, the intervals were not regular, but you were still able to ascertain this sinus rhythm so that you still do get the PQRST complex all the way along, except there's irregularity in the R waves, then we are looking at something called sinus, because we've got sinus rhythm, but it's not quite rhythmic, is it? So it's sinus arrhythmia. Okay, that's in that situation. In our situation, we have got normal sinus rhythm, as in evident in this lead 2 in our strip over here. The next thing I then look at while I'm on this lead 2 is I look at the PR interval. Okay, the PR interval. Now, if you watched my previous video on the basics of ECG, you'll recall that the PR interval is from the start of the P wave to the start of the QRS complex. And that interval should be between 0.12 to 0.20 seconds, i.e. between 3 and 5 small squares. In the given situation, what we've got here, we've absolutely got that, in that we've got our PR interval, which is less than 0.20 seconds, and so this is within normal range. If that was in excess, then that would be prolongation of the PR interval, so what we call PR prolongation, indicative of AV block, which essentially is your first degree heart block. Once I've done this bit, I then move on and I start looking at other things. So then I look at lead 1 and I look at the deflection being positive. Remember, again, if you watch the previous video, you'll recall that this segment over here, the PR segment, not the interval, the segment is essentially sets our baseline, and anything going above that is a positive deflection, anything below that is a negative deflection, okay, from the PR segment, not interval. And the lead 1, your positive deflection here with the QRS complex, And then you can look at either lead 2 or lead AVF, and you can look at the deflection there as well. Okay, and this, looking at this, really, I usually look at this one over here, 1 and AVF, but others will suggest looking at 1 and 2. If you have both deflections which are positive, then this is a normal axis deviation. Okay, normal axis deviation. If lead 1 is positive and lead 2 was to be negative, then the two are away from each other, and that would indicate a left axis deviation. And if the two were facing each other, like so, then this is deemed as a right axis deviation. Now, the way I remember this is I usually say, well, we have to coming together to make the word right. And so coming together makes things right, and that's a right axis deviation. Going away from each other is the opposite, so not talking to each other, not working together, not supporting one another, and things go sideways. They're never right, they're left. And if things are exactly as they are on this ECG, then this is a normal axis deviation. The next thing I then look at for me is I look at our V1 and our V6, and I'm looking here at the QRS complexes. Now again, if you watched my previous video, you will recall that the QRS complex should be no greater than 0.12 seconds, i.e. 3 small squares. If we have a widening of the QRS complex, then this can lead to, or this indicates something called bundle branch block, and we have two bundle branch blocks. We have a right bundle branch block and we have left bundle branch block. And remember, if you have left bundle branch block, which is new and not established, then this gives us room for concern for a myocardial infarction. I'm not going to elaborate on how to delineate from right bundle branch block and left bundle branch block in this video, perhaps on another one. But there are very easy ways to understand that. The next thing and the last thing I'm going to really share here is the situation and how I then look at the actual territories of the heart as represented by the ECG. Now this is probably one of the most important parts of this video, so stick with me. Last thing, I promise. So let's see if this stands out. Okay, so leads 2, 3 and AVF. Okay, you see what I've drawn here? This, as some may say, looks like a boot. Okay, and boots we wear on our feet, which is the inferior most part of your body. And that's what this essentially represents, the inferior aspect of the heart. If you recall your anatomy, you will remember from the coronary circulation of the heart, the inferior aspect of the heart is supplied by the right coronary artery. The next bit you've got is this section here. Okay, and this essentially, if you look at it, is looking at you, it's anterior. Okay, so it's kind of anterior, and that also is anterior, and then this is kind of septal. So this is between, so I say this area here is kind of a divider between this side here of the ECG and this side here of the ECG, i.e. a septum. And this is anterior looking at us, so this is the anteroseptal aspect of the heart. And if you recall again from the coronary research, so this is anteroseptal. Now, if you look at the your coronary circulation of the heart, you recall that the anteroseptal aspects of the heart are predominantly and largely supplied by the LAD, the left anterior descending artery. That then leaves us finally to the last part of the heart, and this again is this bit here and this bit over here. And this bit, these bits over here essentially are, well, this is kind of lateral aspect of the ECG, as you can see, and that also is part of the lateral aspect of the ECG. We don't really look at this lead over here, and we don't really look at this lead over here. I'll undo those so that you can see. Now this lateral aspect of the heart, now notice that this lateral aspect, because it's lateral part of the ECG, actually goes around, doesn't it? It kind of comes around here and then it goes around like that. And that essentially is your left circumflex artery, because it goes around, the circumflex artery goes around. So that's your left circumflex artery. One of the, and as I did say this was the last bit, but something else has occurred to mind. T waves. I wanted to very briefly mention that actually it strikes me. So T waves, if you notice, are all upgoing deflections. They are positive deflections, as you can see here as I'm drawing these. Okay, you can see all these T waves in lead 2 are upward deflections. Now these T waves, the reason I did the territories of the heart is because I will look at these T waves as these territories, okay, because you have to have these defects in concurrent leads. When we say concurrent leads, we mean leads which are related in a territorial fashion. So if I say, for example, I had just an isolated lead, say here, for example, in V2, where I had downward deflections of the T waves. Now remember, again, from the previous video, deflection and negative deflection or flattening of the T wave indicates ischemia, myocardial ischemia, whether that be transmural or subendocardial. But that only becomes clinically significant if the situation is true also for 2 or more concurrent leads. That then starts to give us room for concern. Okay, so that's why I look at the heart in a territorial fashion to look for these T wave inversions, as well as other abnormalities that may be. Now, just before I conclude, it's always worth noting that you'll see, if you did notice, the T waves in my lead AVR here and V1 here are actually inverted. And this is an absolute normal, common exception to the rule that T wave inversion is a result of ischemia. And that's everything. I hope you found that useful. Sorry it was a longer video than normal, but it's my approach, and this is just one of many approaches in the A&E setting for the most part. I hope you enjoyed. Thank you very much.